Hello and welcome to Yashoda Hospitals. I'm Pratyusha Chaudhary, hosting Nursing Education and Training webinar series live on Facebook every Thursday at 3 p.m., bringing forth the most interesting topics. Thank you for joining us today. Stay tuned till the end for the expert panelist discussion. Also, you can post your queries and questions in the chat section, which can be addressed at the end of the webinar. So our topic for the today is comprehensive post-operative management in orthopedic patients. And we have specifically taken this orthopedic topic. So hence, make sure that you will utilize this webinar. Without further delay, let me introduce you to the pros of today's webinar. I take the privilege of welcoming our expert panelist for the day, who is renowned, Dr. Kirti Paladagu, Senior Consultant, Robotic Joint Replacement and Orthoscopic Surgeon for Sports Medicine and Minimally Invasive Trauma, Foot and Ankle Surgeon, Yashoda Hospitals, High-Tech City. We are honored to have you here, sir, and looking forward for your valuable inputs. And also, I'm happy to introduce a speaker for today, Ms. Nivedita Acharya, DGM Nursing, Yashoda Hospital, Secunderabad. I request you to start over the session, ma'am. Over to you.
Thank you. Thank you, Pratyusha. Good afternoon, one and all. Thanks, Pratyusha, for giving a brief introduction about me. I would just take you through today about comprehensive post-op management in orthopedic patients. Thing is, mainly we take orthopedic patients, specifically we have some specific post-op care because they need a lot of management in view of positioning, pain management, and care of all the drains, tubes, everything. Post-operative care. What we mean post-operative care means the care that the patient receives after a surgical procedure. The type of post-operative care that patient need depends on the type of surgery as well as the patient's history. As the patient having kind of diabetic, hypertension, any other comorbidity, the treatment panel will change according to their need. It often depends upon the pain management and wound care also. What are the purposes of post-operative care? To enable a successful and faster recovery of the patient post-operatively, to reduce post-operative morbidity rate because they may come across with some kind of additional problems post-operatively if we will not take care properly the patient of their wound and their pain. To reduce the length of a hospital stay, to provide quality care service to the patients, and to reduce the cost of a patient and the hospital during their post-operative period. What are the nursing care we give during post-operative period? We need to keep the patient bed ready whenever we think that the patient is coming to post-operative ward. All emergency equipment are functioning and available that has to be checked, including oxygen and suction. Patient may have an air mattress if a high risk for developing pressure injury. Whenever we think that the patient is going to be bedridden for a longer time, like femur fracture patients or spine patients, we need to keep the patients post-operatively on bed for longer time. So before itself, we have to take prevention and give them alpha bed as soon as possible. Assess the patient's level of consciousness whenever they are coming from OT, pain level, sedation score, when vital signs are completed. We have to check the vital signs like BP, heart rate, temperature, their saturation level, GCS level, everything. And after that, we have to check the patient's consciousness. Always use safe slides to shift the orthopedic patients from trolley to bed. Safe slides are very helpful to the patients whenever we are shifting from trolley to bed because it gives support from head to toe. And with two people only, we can shift the patient from one bed to another bed. Take care of the drains and catheters because every patient coming from OT mostly will have drains and catheters, and those drains and tubes will be entangled with kind of trolley or bed accessories. So we need to take care of drains and catheters while shifting to the bed. And we have to check very importantly the bandage. All the patients gone through orthopedic surgery will have dressings and bandages. We have to check for the soakage, as it is a sign of like bleeding post-operatively. And these are the care, consciousness care we have to take. We have to check whether the patient is alert or the patient is responding whenever we are talking to the patient, or the patient is giving stimulus, giving response when we are giving pain stimulus, or whatever we do, patient is not responding. That means unresponsive. What are our aim of post-operative care? Monitoring vital parameters at regular interval, every 15 minutes for first 2 hours, then every 30 minutes till we send the patient to the ward or ICU. What all the vital monitoring we need to do? Heart rate, ECG, BP, temperature, saturation, urine output, and mainly pain score. Why I have stressed means during the post-operative period, the level of satisfaction from the patient will come when there will be zero pain or no pain. Prevent immediate complications such as bleeding, accidental removal of drains and catheters. Promote healing of the surgical wound and prevent SSI. Return the patient to normal state of health. These should be our aim. Acute pain management. Here in Yashoda Hospital, we have a team of pain management, which is headed by one of our consultant anesthesiologists, to extend the comprehensive care to all post-operative patients, even after shifting from a PSU or SICU. Team, the junior doctor, and there is a nurse also, they are visiting the patients next day also after to the patient's bed, and they ask the patient whether they have the pain, they need the epidural catheter to be continued, or they can remove the catheter if the patient is comfortable with their oral analgesic. And in addition to that, after 24 hours, the physiotherapy consultation also taken and started physiotherapy, which will heal which will support for a faster recovery. These are the main kind of surgeries, major surgeries in orthopedic, and these are the preferable positions which I have shown in the pictures. Like after T-care, we keep the patient's leg straight underneath one small pillow, which will support the knee. And here ACLR also, the scopy ports will be closed with sterile dressing, and the support is given after bilateral tibia and fibula. So we need 2 different people to support for any kind of a movement. And after THR also, we need to keep in these kind of 2 positions whenever the patient comes from OT. Comes to intake output chart. Intake output chart is very important for any kind of, not only ortho, any kind of surgery, patients gone for surgery. Our goal should be to maintain a zero balance. There should not be like fluid retention, or there should not be kind of dehydration. So as per our nurses calculation, we feel that the requirement for fluid is 60 ml into 30. So 1,800 ml for one day we have to give, means our calculation comes to 75 ml per hour. As a normal body weight of 60 kg patients, we can give 70 to 75 ml per hour continuous fluid. Whenever the patient is on NBM, they are not taking anything till they continue their oral fluids or they stop NBM. That time we have to continue the IV fluids. It may vary. When the patient is having fever, the requirement for fluid also will increase. Or if there is a high amount of blood loss during surgery, then also the fluid requirement will increase. In case of reserved blood, the anesthetist or surgeon, they will advise for blood transfusion, or else at least for the fluid management, we have to compensate with IV fluid first. In case of an anemic patient gone for surgery, or there is excessive blood loss during surgery, or even after surgery also, patient lost lots of amount of blood, then blood transfusion is advised by the doctor, either anesthetist or surgeon. Then we have to initiate a blood transfusion, which was reserved, or we have to reserve that point of time also. And there are certain medications which has to be administered to the patient with advice of surgeons or anesthetist. Those are importantly antibiotics. As patient has gone for surgery, we have to give antibiotics and analgesic anyway to control the pain, and venous VTEs, because to prevent like thromboembolism, we have to give heparin or Clixin after 12 hours of surgery, or according to the instruction of the surgeon. Other regular medications, if the patient had even before, like any kind of diabetic, hypertensive, or blood thinner, TB medications or thyroid, again it has to be resumed on its regular time. And we nurses should emphasize for early ambulation. There are lot of advantages of early ambulations, like it stimulates the blood circulation, improve flexibility of all the limbs, assures faster healing, prevent constipation. Once patient will move, the bowel movement also will be initiated, and constipation can be also prevented. Prevents urinary infections, prevent pressure ulcers, enhance self-esteem. Then the patient also will not feel that I am going to be depend on someone. I can work better. I can take care of myself. There are few points which we should do after surgery and we should not do after surgery. Like do's: follow instructions of the surgeons, watch out for infection. If there is any signs of infection, please reach out to the doctor. Ask for any kind of help whenever necessary. Take necessary rest, whichever is advised, like the doctor will advise for 3 months or 2 months or 2 weeks rest. Eat properly nutritious diet for faster recovery. Cough carefully. If we are coughing very vigorously, then our fractured bone, which was joined by plate and screws or some kind of K-wire, it may get dislodged. Wash your hands every time. Get moving. Don't sit in one place, and prepare your home. And comes to do not drive too soon. Don't drive too soon. Post-operatively, till your doctor gives permission for driving. Don't lift heavy objects, like very heavy, full of water bucket or a very heavy luggage. It is not advisable soon after the surgery. Do not smoke. Skip appointments. Don't skip appointments. Whenever it was advised, you should meet the doctor at that correct point of time. Sports: ignore infections. Any signs of infections you get, like some kind of skin irritation or some anytime you get fever, don't neglect it. As soon as possible, please meet your experts. Don't strain your body. How much your body permits you work, only that much. Stop antibiotics. Whatever the prescribed antibiotics was given, like for 1 week or 10 days or 5 days, even after going home, oral antibiotics, that has to be continued as per the advice of the doctor. And don't overuse pain medications. Whatever pain medications is advised by the doctor, you should take that only. Now I am having more pain, I should take 2 tablets of same aceclofenac. Don't do that. And this is another like first hugs bit, one kind of like short forms. We just for remembering, great remembering. F for feeding. After either for the medical patients or for the surgical patients, feeding is very much important. Either we should continue the NBM or we have to start enteral feeding or parenteral nutrition. Anything, we have to take care of the feeding first. Next is A, analgesics. Analgesics are very important as post-operatively patients and mainly orthopedic patient will have severe pain, which can be controlled only by analgesics. S for sedation or sensorium, like GCS score, how much patient is conscious we have to measure. T for thromboprophylaxis. Thromboprophylaxis, and for surgical patients, temperature also same important, and tubes and catheters. I have explained about tubes and catheters during my previous slides also. H, head up. Keep the patient little bit head up positions, and we have to check the hemodynamics for all surgical patients additionally. U, ulcer prophylaxis and urine output. Ulcer prophylaxis means to provide alpha bed or air bed. G for glycemic control. If the patient is a diabetic, we have to check the blood sugar very frequently as advised by the doctor, at least thrice a day, and do the sugar control by insulin or any kind of AHS. S, oxygen supplement through mask, NIV, or high flow concentration of oxygen also. B for take care of bowel movements. I, indwelling catheters. There are good number of catheters are available in the patient when the patient comes from OT, like epidural catheter, Foley's catheter, everything. And D for drug, like patients de-escalations, drug de-escalation should not be there, and delirium. Thank you.
Thank you, Nivedita ma'am. That was a crisp presentation about the comprehensive post-operative management in orthopedic patients. And here, the panel is open for the discussion. Kindly post your questions in case if you have any queries that we want to address during this webinar. And now let us welcome our expert panelist, Dr. Kirti sir, on board. Welcome, sir. We are really honored to have you and the expert panelist for today's topic.
Hello, everyone. I'm really sorry for the delay, as always.
We understand your busy schedule, sir, but still we thank you a lot for joining us today.
Yeah.
So we have few questions that we wanted to ask you.
Yeah.
What are the basic principles that the nurses needs to follow immediately after an orthopedic surgery? Let's take a TKR or hip replacement surgery.
As already sister has explained, ma'am has already explained, first thing and the foremost important thing is the early mobility. The faster you mobile, first thing you give the patient is the confidence. If you operate in the morning and by evening, if you're making them mobile, at least off the bed or a couple of steps, it gives them a lot of confidence. And next day when they come back for the physio, they'll be with the thought process like, when I have done it yesterday, why won't I do it today? So they are self-motivated. That is the most important thing. So that one was very much impressed with the thing what ma'am has emphasized on. I was very much impressed with that. Second important thing, what I tell all my fellows or my nursing staff here to check is like, even we check once the surgery is done, we check for the vascularity. First most important thing is vascularity, especially when we do the joint replacements, especially the knee, distal pulses. So once the patient is shifted to the ICU, as our part, we are doing it, we are checking, we might document it. To double check that, just put a probe to the great toe or the second toe and see for the saturation. If the saturation, if you feel it's cold or any fluctuation in the saturation, just inform the consultant so they have a double check with that. If there is any constriction of the bandage, sometimes the bandages might be very tight. We do the surgery, we check the pulse. Later on, I will ask my fellow to do the dressing. He might have put it very tight. Even if that there will be some constriction kind of a thing. The vascularity will be compromised and will end up in some amount of swelling, and it will in turn cause a lot of pain. So always check for the pulses, warmth of the limb immediately once you receive the patient. And next important thing is like 4 to 6 hours, there will be effect of anesthesia. Once the anesthesia is waned off, ask the patient to do the ankle movements actively. And once it is documented, I tell my sisters or my fellows to immediately let me know what is the status of the neurovascular status. So I prefer that has to be updated to all the consultants. And also have a check with the ILS, how the bowel sounds are there, how bowel movements are there. And most important thing, what ma'am was emphasizing was breaking on the NBM.
Yeah.
You have to feed the patient. And for not only the immediate post-operative patients, whenever the patient is within the hospital, we should teach the attendants mainly that you are feeding a patient in a sitting position. Never ever let it be water. Even if it is water also, never ever in lying down position. It might in turn choke your lungs and it will cause pneumonias and all. The most commonest cause of chest infections and deaths are only because of this improper feeding, even after they go back home. So take time, all of us should take time to teach the patient as well as the patient attendants the importance of giving the tilt. Some patients might be bedbound. Even in them, we have to give a tilt of at least 30 to 40 degrees and then feed them, even if it is water. In the middle of the night, make sure that we are teaching our patient attendants, and then only we are discharging them. And emphasize on that. Every time any of the sister or the consultant going to the patient regarding the feeding, you make sure that you are telling this to the patient at least 5 to 10 times in a day. We'll be interacting with them. So every time you go, you tell the same thing that has to be stuck in their brain, and they follow the same thing when they go back home. This is one thing what I've seen in most, especially with the hip fractures, the elderly patients, or even the spine injuries, spine fractures. They'll be more scared to mobilize the patient. We should make them have that confidence that nothing happens even if you move to that extent, or even if it is painful, you have to do this mobility because life is more important than we are going through the pain. This is one most important thing what I would like to emphasize on the feeding plan.
So one more thing, in case if there are red flags in the post-operative management, what red flags the nurse needs to really focus, and she needs to work on that? What might be the areas of red flags after the
most important, especially when you come across with the orthopedic surgeries, the red flags would be, first thing would be cardiac, heart, like any changes in the fluctuation in the BP, or there is changes in the ECG pattern on the monitor, or there is saturation drop. You have to work hand in hand with the cardia as well as the lungs. So these things we have to see. Embolisms is what we see very commonly, especially when we do the femur nailings or hip replacements and total knee replacements, or especially when we do it bilateral, we'll be seeing subclinical embolisms, pulmonary thromboembolisms, PTEs. So first important thing in these things would be drop in the saturation. Patient may not complain. Patient will never complain like I'm having desaturation, I'm feeling breathlessness and all. It is our duty to recheck on the saturation levels. If it's around 90 to 95, a liter of oxygen should be helpful. So the consultant has to be intimated and the intensivist will be taking care of the things. If it is falling lower, then make sure it has been documented, informed to the consultant, and further investigations if required, like CT, pulmonary angio, and all those things to be looked into. That is mainly for the sake of documentation, because anyway, even if you do the CT pulmonary angio, if there's a significant block, we will not do the intervention. It's the same Clexane or any antiplatelet, whatever is preferable for the patient, it will be given as per the dose and the body weight. So that is the most important thing what we see in an
commonly the red flags.
Post-operative thing. And second important thing is never hesitate to get the ECG or a 2D codon. If any doubt is there, you are not able to rule out anything, saturation still dropping, BP is not, you're persistently having the hypotension or persistent on the higher side. So go get your review with the cardiologist, get an ECG done, and recheck it, and get the 2DA code and reconfirm with the same thing whether it is there pre-operatively, and if there are any changes in the post-operative period. And last but not the least, it may be the very rare complications. Stroke is one thing what we have to look into, because we are dealing with the geriatric patients.
Yes.
So many a times they never complain. There'll be hypertension or hypertension. Even the malignant hypertension might end up in a stroke, wherein your mobility, you have to check for the movement of all the four limbs or speech, any deviation of the mouth, not able to take the fluid inside, not able to bite, chew, or something like that. We have to suspect stroke and go for an immediate CT or an MR stroke protocol, whatever is required and suggested by the consultant. These are the main red flags what we see.
In case if we talk about the compartmental syndrome, how can we prevent this?
It will take certain time. That's what I told you. No, once you come back to the SICU, first important thing is you check the pulses. I have already checked my pulses of my patients. I have sent across to the ICU. In between, there might be some compression bandages or some amount of swelling might be increased post-operatively, whatever might have happened. Check for the pulses, warmth of the limb, and the saturation. Once you put a probe and see, check, and keep doing that. Compartment syndrome won't just set in within like a couple of hours or something like that, unless there is a really bad vascular injury or something like that. Even in those scenarios also, to have a set-in compartment syndrome, it takes 4 to 6 hours time. We shouldn't wait for those symptoms to set in. So before that, these checkpoints like saturation, warmth, and pulses, palpating the pulses to be looked into. And if at all, unfortunately, the compartment syndrome is set in, don't hesitate, take him back to the theater and give the compartment release. There's no alternative for that. To prevent these things, we are asking the patient to do the ankle movements, keep it elevated, and all those things. But once the compartment is set in, don't think twice. Just push him back to the theater, counsel the attendants, and release the compartment. We are saving the limb by doing that.
Great. If we want to give a take-home message for our nurses, the top 5 things that they need to remember when they're handling the post-operative patients, especially the orthopedic patients. So what would be your take, sir?
First is feeding. As I already elaborated in detail, feeding, most important thing. Teach the attendants how to feed. Don't pamper the patients. Even though if it is painful, try to motivate them, give them that confidence and make them sit or tilted. At least when you're giving, even if it is a water, it has to be done. That is the first and most important thing what I would like to tell. Second thing is give confidence to them, talk to them, spend more time with them, and make them confident to move off the bed as early as possible. Especially in a replacements and all, we make them walk from day one. And in any trauma surgeries, either it is a nailing or this thing, we might go with the non-weight bearing. If they are good to go with one leg, if it's a geriatric patient, it may be difficult. If it is difficult to move on one leg, at least make them mobile on the bed, make them sit, make them do the quadriceps or static exercises. This is one thing what we would like to see. And always ask them to make a note of the most common calls what we get post-operative after they get discharged is patient is having fever. For 9900, never ever bother about the fever. It's all because of the medication what we give commonly and lack of fluid intake. Patients stop taking water with the fear of mobility towards the washrooms frequently. With that fear, they will restrict the water. With that also having some amount of temperature. So encourage them to take more fluids. And one concern here we have to look into would be any patient with a cardiac failure or a kidney failure, restrict the fluid intake. Otherwise, encourage them to take more of a fluids. It can be water, juice, or anything, tender coconut, whatever they want, they can. And also emphasize on the food that they can eat everything. Many of the patients will come back and ask you, shouldn't we eat the white colored thing? Shouldn't we eat the rice too? Shouldn't we eat some XYZ things? Make sure that they are all required for the healing. It's not like there's no restriction of food kind of a thing, unless they're diabetic or some additional things are to be needed. You don't require those things. And also we should educate them that eating a non-veg or having bone soups and all is not going to heal your bone faster. So let the patient eat whatever she's comfortable and whatever she's used to all these years, not to force onto the things telling that having bone soups is going to create some magic and heal the bones. Main thing is mobility. And if any red alarm says, you have to teach them continuous running fever, any discharge from the wound, patient is feeling breathless, check for the saturations, any seepage from the surgical site, all these things are happening. So let them rush back to the hospital. We are here to take care of the things. Don't have like, we'll wait for a day and see if it's not subsiding, then we'll go for the next day kind of it. So
thank you so much, sir. It was really amazing that to have you here. We are really honored to have you here in the nursing fraternity for the webinar.
thank you.
I know you are totally busy, packed up with so many things, and I also
I feel it's a taunt. At Hypex, we are not really busy at this point. You people should make us busy.
Thank you so much, sir. Thank you, Nivedita ma'am. Also, I thank Shanti ma'am for looking forward for the help in future also. That was an amazing discussion that we have got today. And again, for the next week, we are coming up with a super most good topics that you will be interested in. And stay tuned to Yashoda Hospitals Facebook page. And if you like our webinars, please do share it onto your media. Thank you so much. Stay tuned to us.
Thank you all. Good day.
Thank you, sir. Thanks, Pratyusha.
Thank you, ma'am.